There is a reason that high blood pressure has earned the nickname the silent killer, and that reason is not metaphorical or dramatic exaggeration. It is a precise and accurate description of how this condition actually behaves in the body over time. It produces no pain. It causes no obvious symptoms in its early and middle stages that would naturally prompt a person to seek help. It does not announce itself the way a broken bone announces itself or the way an infection announces itself. It simply sits there, quietly, relentlessly, doing damage to blood vessels and to the organs those blood vessels serve, accumulating consequences that may not become apparent for years or even decades until the damage has reached a threshold where something serious happens: a heart attack, a stroke, kidney failure, vision loss, and suddenly what had seemed like an invisible problem reveals itself as one of the most significant health issues a person has been living with for years without knowing it or without taking it seriously enough to address. For adults over 60, this story is not abstract or hypothetical. It is the lived reality of an enormous proportion of the older population. High blood pressure, which physicians call hypertension, affects approximately 2/3 of adults over the age of 60 in most developed countries, and the proportion rises further with each subsequent decade of life, reaching rates that some research suggests affect nearly 3/4 of adults over 75. These numbers are staggering when you sit with them for a moment. They mean that if you are over 60 and you gather a group of your friends or neighbors of similar age, the statistical reality is that most of them have high blood pressure, and a meaningful proportion of those who have it either do not know they have it, or know but do not fully understand what it means, or know and understand but are not managing it as effectively as they could and should be. The consequences of this widespread under-recognition and under-management are measured in the millions of heart attacks and strokes and episodes of kidney disease that occur every year in people who might have been protected by better blood pressure control. Understanding blood pressure begins with understanding what it actually measures and what the numbers mean. Because many people have been told their blood pressure is high without having had anyone explain clearly what that means in terms of what is physically happening in their body and why it matters. When the heart beats, it pumps blood through a vast network of blood vessels that extends through every part of the body. The force that the blood exerts against the walls of those vessels as it moves is what blood pressure measures. Two numbers are used to express this force. The higher number, called systolic pressure, measures the force exerted when the heart contracts and pushes blood out. The lower number, called diastolic pressure, measures the force when the heart is between beats and refilling. These two numbers together describe the constant mechanical stress that the blood vessel walls are under, and when that stress is elevated above what those walls are designed to comfortably accommodate over the long term, the cumulative damage begins. The current clinical guidelines generally define high blood pressure as a reading of 130 over 80 millimeters of mercury or higher, though the specific thresholds used in clinical practice have shifted somewhat over the years as evidence has accumulated about the blood pressure levels at which risk begins to meaningfully increase. For adults over 60, there has been genuine scientific debate about what the target blood pressure should be in older age, because the biology of blood pressure in aging bodies has some specific features that make the question more nuanced than it might seem. Blood vessels become stiffer with age, a process called arteriosclerosis, and this stiffening tends to push systolic pressure higher, while diastolic pressure may remain stable or even decrease, producing what is called isolated systolic hypertension, which is the most common pattern of high blood pressure in older adults, and which carries its own specific set of risks and management considerations. The debate within medicine about blood pressure targets in older adults has been clarified considerably by the results of several major clinical trials, most notably one called the SPRINT trial, which examined whether targeting systolic blood pressure below 120 rather than below 140 in adults over 50 produced better cardiovascular outcomes. The results were significant and practice-changing, showing meaningful reductions in heart attacks, heart failure, and death in the group treated to the lower target, but also showing that achieving that lower target came with some increased risk of certain side effects, including dizziness, fainting, and kidney function changes. The overall clinical message that emerged from this and related research is that lower blood pressure targets generally produce better cardiovascular outcomes in most older adults, but that the specific target needs to be individualized based on a person's overall health status, their other medical conditions, the medications they are taking, and their specific vulnerability to the side effects of more aggressive blood pressure treatment. This individualization is one of the most important concepts for older adults to understand about blood pressure management, because it means that what is the right blood pressure target and the right treatment approach for one person over 60 is not necessarily the right target and approach for every person over 60. Frail older adults with multiple medical conditions who are at significant risk of falls may benefit from slightly less aggressive blood pressure targets than robust older adults with otherwise good health who can tolerate more intensive treatment without undue risk of side effects. This is a conversation to have with a healthcare provider who knows the full picture of an individual's health, not a decision to make based on generalized population guidelines without that individualized context. What is not in question and not subject to individualization in the same way is the fundamental importance of knowing your blood pressure and of taking it seriously when it is elevated. The first step in addressing high blood pressure is measuring it accurately, and this is less straightforward than it might seem. Blood pressure is not a fixed number. It varies throughout the day in response to activity, stress, caffeine, position, and many other factors, and a single reading taken in a clinical setting captures only a moment of that variation. The phenomenon called white coat hypertension, in which blood pressure rises in the clinical setting due to the anxiety many people experience in medical environments, can produce readings that overestimate true blood pressure. Conversely, masked hypertension, in which blood pressure appears normal in the clinical setting but is elevated at home, can produce a false reassurance that blood pressure is well controlled when it actually is not. For these reasons, the standard of care for blood pressure assessment has increasingly moved toward home blood pressure monitoring and 24-hour ambulatory monitoring, which provide a much more accurate picture of what blood pressure is actually doing across the course of a person's typical day. Home blood pressure monitors have become accurate, affordable, and easy to use, and the information they provide, particularly when readings are taken at consistent times in a consistent way and recorded over time, is genuinely valuable, both for initial assessment and for ongoing monitoring of treatment effectiveness. The American Heart Association provides clear guidance on proper home blood pressure monitoring technique, including sitting quietly for 5 minutes before measuring, using the upper arm rather than the wrist for most people, taking 2 readings a minute apart and averaging them, and measuring at the same times each day, typically morning before medications and evening before bed. The reasons that blood pressure tends to rise with age reflect several of the same biological processes that underlie other aspects of aging. The progressive stiffening of blood vessels, which reduces their elasticity and makes it harder for them to accommodate the pulse of each heartbeat without a significant pressure wave, is the primary contributor to the rising systolic blood pressures that are so common in older adults. The kidneys, which play a central role in regulating blood pressure through their control of fluid and electrolyte balance, show some decline in function with age that can affect the body's ability to maintain optimal blood pressure regulation. The autonomic nervous system, which controls the automatic adjustments that blood pressure makes in response to changes in posture and activity, also becomes somewhat less precise with age, contributing to the pattern called orthostatic hypotension, in which blood pressure drops when standing up, which coexists with overall hypertension in many older adults and creates specific management challenges. The damage that uncontrolled high blood pressure does to the body is worth understanding in some detail, because abstract knowledge that high blood pressure is bad for you is considerably less motivating than a clear picture of the specific mechanisms by which it causes harm. Blood vessels are not passive pipes. They are living structures with active biological functions, and the constant mechanical stress of elevated blood pressure damages them in several specific ways. The inner lining of blood vessels, called the endothelium, becomes dysfunctional under the chronic stress of high pressure, losing some of its ability to regulate vessel tone and becoming more prone to the inflammatory processes that contribute to the buildup of plaques inside vessel walls, the process called atherosclerosis that underlies heart attacks and many strokes. The heart itself is directly affected by sustained high blood pressure because it must work harder to pump blood against elevated resistance in the blood vessels, and this increased workload causes the muscle of the left ventricle, the main pumping chamber, to thicken over time in a process called left ventricular hypertrophy. While thickening initially represents the heart adapting to increased workload, over time this hypertrophy leads to a heart that is less flexible, less efficient, and more prone to the rhythm disturbances and the heart failure that represent some of the most serious cardiovascular outcomes associated with uncontrolled hypertension. The kidneys are damaged by high blood pressure through the same vascular mechanisms, with the small blood vessels that filter waste from the blood becoming progressively damaged by elevated pressure in ways that impair kidney function and can ultimately lead to kidney failure requiring dialysis. The brain is perhaps the organ whose vulnerability to high blood pressure deserves the most emphasis in a conversation specifically aimed at older adults, both because of the severity of the outcomes that hypertension-related brain damage can produce, and because of the emerging research on connections between blood pressure and cognitive function that go beyond the obvious and dramatic consequence of stroke. The connection between uncontrolled hypertension and stroke is well established and probably familiar to most people, with high blood pressure being the single most important modifiable risk factor for stroke, responsible for an estimated half of all strokes worldwide. Both the ischemic strokes caused by blocked blood vessels and the hemorrhagic strokes caused by ruptured blood vessels are strongly associated with hypertension, and blood pressure control is one of the most effective interventions available for stroke prevention. Less widely appreciated but increasingly well documented is the connection between sustained high blood pressure, particularly in midlife and early older age, and the development of dementia decades later. The research in this area has grown substantially in recent years, and the picture it paints is concerning in its implications and important in its potential for prevention. High blood pressure appears to contribute to dementia risk through multiple mechanisms, including the cumulative effect of small vessel damage in the brain that produces what is called white matter disease or small vessel disease, and through the same inflammatory and vascular mechanisms that contribute to cardiovascular disease more broadly. Studies have found that people who effectively control their blood pressure in midlife have significantly lower rates of cognitive impairment and dementia in later life compared to those whose blood pressure was poorly controlled, providing a compelling argument for aggressive and consistent blood pressure management that extends well beyond just protecting the heart. The management of high blood pressure in older adults involves both lifestyle interventions and, for many people, medication and understanding, both in some detail, is important for anyone navigating this condition after 60. The lifestyle interventions that have the most robust evidence for blood pressure reduction include dietary modification, physical activity, weight management where relevant, sodium reduction, limiting alcohol consumption, and stress management, and the combined effect of several of these interventions together can be substantial, in some cases, achieving blood pressure reductions comparable to those produced by a single blood pressure medication. The dietary approach with the strongest evidence base for blood pressure reduction is the DASH diet, which stands for Dietary Approaches to Stop Hypertension, and which was developed specifically through research designed to identify the dietary pattern most effective for blood pressure control. The DASH diet emphasizes fruits and vegetables, particularly those rich in potassium, which counteracts the blood pressure-raising effects of sodium, whole grains, lean protein including fish and poultry, low-fat dairy products that provide calcium and other minerals important for blood pressure regulation, and nuts and legumes. It emphasizes reducing sodium, red meat, added sugars, and saturated fats. Studies of the DASH diet have consistently found blood pressure reductions of 8 to 14 millimeters of mercury systolic in people with hypertension, which is a clinically meaningful reduction comparable to the effect of starting a blood pressure medication. Sodium reduction deserves particular emphasis because the sensitivity of blood pressure to sodium intake tends to increase with age, meaning that older adults often show more significant blood pressure responses to sodium intake than younger adults do, and consequently can also show more significant blood pressure reductions from sodium restriction. The current recommendation for adults with high blood pressure is to consume less than 2,300 milligrams of sodium per day, with some guidelines suggesting even lower targets of 1,500 milligrams per day for those with established cardiovascular disease or diabetes. The challenge of meeting these targets in the context of a modern diet is significant, because the majority of dietary sodium in most people's diets comes not from the salt shaker, but from processed and packaged foods, restaurant meals, and prepared products that contain sodium in quantities that are not always obvious from casual food choices. Developing the habit of reading nutrition labels and choosing lower sodium options within food categories is a more achievable and more sustainable approach than simply telling people to use less salt, since the salt added in cooking and at the table represents a relatively small fraction of most people's total sodium intake. Physical activity is another pillar of blood pressure management with a strong evidence base. Regular aerobic exercise, including walking, cycling, swimming, and other forms of sustained moderate intensity activity, produces measurable reductions in blood pressure that are in the range of 4 to 9 millimeters of mercury systolic, and these reductions occur through several mechanisms including improvements in blood vessel function, reductions in the activity of the nervous system components that drive blood pressure up, and improvements in kidney function. For older adults, the type and intensity of exercise needs to be appropriate for their overall fitness level and health status, and the guidance of a healthcare provider or physical therapist in developing an appropriate exercise program is valuable, particularly for those who are starting from a very sedentary baseline or who have other health conditions that affect exercise capacity. But the fundamental message is that movement matters significantly for blood pressure control, and even modest increases in physical activity from a sedentary baseline produce meaningful blood pressure benefits. When lifestyle interventions alone are not sufficient to control blood pressure to target levels, which is the case for the majority of older adults with established hypertension, given the magnitude of blood pressure elevation that many people present with, medication becomes part of the management strategy. The classes of blood pressure medications available today are varied in their mechanisms of action and their side effect profiles, and the selection of appropriate medication or medications for any individual involves consideration of their specific blood pressure pattern, their other medical conditions, the medications they are already taking, their kidney function, and other factors that make medication selection genuinely individualized rather than one-size-fits-all. Several classes of medications are commonly used as first-line treatment for hypertension in older adults. ACE inhibitors and the related angiotensin receptor blockers, sometimes called ARBs, work by blocking components of a hormonal system called the renin-angiotensin system that regulates blood pressure and fluid balance, and they have the additional benefit of protecting the kidneys from the damage that high blood pressure causes, making them particularly valuable choices for people with diabetes or existing kidney disease. Calcium channel blockers work by relaxing the muscle in blood vessel walls, allowing vessels to widen and reducing the resistance against which the heart must pump, and are particularly effective for the pattern of isolated systolic hypertension common in older adults. Thiazide diuretics work by reducing the amount of fluid in the bloodstream and have a long track record of effectiveness in older adults with good tolerability in most people. Beta blockers, which reduce blood pressure partly by slowing the heart rate and reducing the force of heart contractions, are another class of blood pressure medication that is particularly useful when hypertension coexists with certain other heart conditions, including irregular heart rhythms or coronary artery disease, though they are not typically preferred as initial treatment for hypertension in older adults who do not have these additional indications. Many older adults with hypertension require more than one medication to achieve adequate blood pressure control, and combination therapy using two or more medications from different classes is very common and entirely appropriate, as the combination of smaller doses of multiple medications with different mechanisms can often achieve better control with fewer side effects than higher doses of a single medication. The management of blood pressure medications in older adults requires particular attention to several concerns that are more significant in this age group than in younger people. The risk of blood pressure dropping too low with treatment, particularly when standing up, is a genuine concern in older adults because orthostatic hypotension is both more common with aging and more dangerous given the fall risk it creates. Monitoring for dizziness, lightheadedness, or unsteadiness when rising from sitting or lying positions, particularly after starting or increasing blood pressure medications, is important, and any significant symptoms of this kind should prompt a conversation with a healthcare provider about whether medication adjustments are warranted. The interaction between blood pressure medications and other medications is another important consideration for older adults who are often taking multiple medications for multiple conditions simultaneously. Some medications commonly used in older adults, including certain anti-inflammatory pain medications, some decongestants, and some supplements, can raise blood pressure and reduce the effectiveness of blood pressure medications, while other combinations can produce additive blood pressure, lowering effects that increase the risk of the pressure dropping too low. Maintaining a complete and current list of all medications and supplements being taken and sharing that list with every healthcare provider involved in a person's care is essential for safe medication management in the context of blood pressure control. Adherence to blood pressure medications, actually taking them consistently as prescribed, is one of the most significant practical challenges in blood pressure management and one that deserves honest acknowledgement. Research consistently finds that a substantial proportion of people with hypertension are not taking their medications consistently, and the reasons for this are varied and understandable. Side effects, cost, the inconvenience of daily medication taking, and the fact that hypertension causes no symptoms and therefore provides no immediate experiential feedback about whether the medication is working all contribute to the challenge of medication adherence. Strategies that can help include using pill organizers or medication reminder apps, linking medication taking to established daily habits like brushing teeth or having a first cup of coffee, discussing side effects promptly with healthcare providers rather than simply stopping medications unilaterally, and understanding clearly why blood pressure control matters even in the absence of symptoms. Monitoring blood pressure regularly at home and keeping a record of readings to share with healthcare providers gives both the individual and their provider much better information about how well blood pressure is controlled and whether adjustments to the management plan are needed. The gap between the blood pressure a healthcare provider sees at an office visit and the blood pressure a person is experiencing throughout their daily life can be significant, and home monitoring provides the information needed to bridge that gap. Investing in a good quality, validated home blood pressure monitor and learning to use it correctly is one of the most valuable tools available for anyone managing hypertension over 60. The psychological dimension of living with a chronic condition like hypertension deserves acknowledgement as well. The diagnosis of high blood pressure can feel alarming, particularly given the serious outcomes it is associated with, and the anxiety that sometimes accompanies this diagnosis can itself have negative effects on blood pressure and on quality of life. Understanding that hypertension is extremely common, that it is manageable through the combination of lifestyle intervention and medication, and that the outcomes most feared, heart attack, stroke, and kidney disease, are significantly preventable through effective management, provides a more accurate and more empowering framework than one of passive fear of a dangerous condition beyond a person's control. High blood pressure after 60 is serious. It is also manageable, and the management tools available are more effective and more accessible than they have ever been. The most important message that any honest conversation about high blood pressure after 60 should deliver is a simple one. Know your numbers. Measure your blood pressure regularly. Understand what your readings mean in the context of your overall health. Take the management of elevated readings seriously, whether through lifestyle changes, medication, or most likely both. Follow up with a healthcare provider regularly to assess whether your management approach is achieving adequate control. And do not accept the silent nature of this condition as a reason to ignore it. The silence of high blood pressure is not reassurance. It is the very characteristic that makes it most dangerous, the fact that it causes no pain, no obvious distress, no clear signal that anything is wrong, right up to the moment when the accumulated damage produces a consequence that is neither silent nor manageable in the same way. Prevention is always better than response to crisis. And in the case of high blood pressure after 60, prevention through effective management is genuinely achievable for the vast majority of people willing to engage with it seriously and consistently.